All right. Hi, everybody. We are live here at the Taking Control of Your Diabetes office. I am Jeremy Pettis. This is my good friend and colleague,
Steve Edelman.
Yes. And we are both endocrinologists, University of California, San Diego, taking care of patients with type 1 and type 2 diabetes. We also have both been living with type 1 diabetes ourselves since we were 15.
Yeah, 25 years apart in the diagnosis, but both 15 years old. And, you know, I also work at the Veterans Hospital, so does Jeremy. And we're here to talk about heart disease. And even though the title of this Facebook Live is for people with type 2 diabetes, which will focus, us type 1s are sharing medications with type 2s, and we'll get into that.
Yeah, and I think, you know, we wanted to be comprehensive and talk about basically medications in general. And we're going to, focus a lot on type 2 diabetes, but this is the questions that we get the most. I mean, being endocrinologists, we're helping people with diabetes choose the right medications, when they should start them, et cetera. So maybe it's worth just starting actually talking about kind of our approach to diabetes in general. I think a lot of times, people get confused with why are they having to add medications instead of substituting. So that really is kind of the name of the game that we, when we treat people with diabetes, unfortunately, over time, it generally gets harder for people to control their blood sugars. And that's because type 2 diabetes is actually a progressive disease where the beta cells that make insulin can die or become dysfunctional. So where you used to be able to control your blood sugars with just some diet and exercise, now you need one medication, now you need two medications, now you need three medications. And people are generally saying, I want to get off of these things.
Right.
Why do we keep having to add things? So how do you help people with that kind of approach?
Yeah, you know what? Just one step back, us folks with type 1, our pancreases do not secrete hardly any insulin. We're on insulin for life, and things don't really change that much except as we add new technologies. But as you mentioned, when you get type 2, when you're first diagnosed, your pancreas is actually secreting a lot of insulin, but the cause of type 2 diabetes is the insulin that the pancreas secretes doesn't work well. It doesn't get the glucose out of the blood into the cells for utilization. So your pancreas is working overtime trying to keep things normal. And it does that for quite some time. But as you mentioned, we call this beta cell burnout, beta cell exhaustion, and this happens over time. So you might be doing everything right. You might be following a good diet and exercise, taking your medications, being super adherent, and then your doctor says, hey, your A1C is creeping up. We're going to add something. And I know that really gets people down. So I think in answer to your question, I think explaining to people what this progressive nature of diabetes is, and it's so different from type 1s.
Yeah.
Type 1s, boom, you're on insulin and that's it. And type 2s, your therapy may change over time. And the most important thing that you should keep in mind is that what is your A1C?
Yeah.
And if that's good, I don't care if you're on 10 drugs, and you shouldn't either. And people go around bragging, I'm not on any medication. Their A1C is 13%, their blood sugar is 200 to 300. They're prone to all kinds of complications. So it's a mindset. And trust us, we don't get a kickback from the drug companies when we prescribe their drugs. We don't. Our goal is to get folks on the safest and most effective medication to get the glucose under control. But now, in the new era of type 2 diabetes, is that we're focusing on heart and kidney disease. And that's really important. Why don't we, you want to talk about like the new treatment algorithm that doctors get?
Yeah, so, again, when somebody has type 2 diabetes, there's a whole bunch of medications that we can use, which is the good news. The bad news, I guess, is how to pick the right one and kind of in which order. So typically when somebody's first diagnosed with type 2 diabetes, let's say your blood sugars are mildly elevated, your provider might reasonably say, let's really work on some diet and exercise and these kinds of things. And if you lose 5%, maybe a little bit more of your body weight, you really can help stabilize your blood sugars. Everybody with type 2 diabetes, their goal should be at least to maintain their weight, if not losing weight. That 5-7% is kind of what we target.
Let me just quickly interrupt. Yeah. I think that's a great point. Maintaining your weight is a victory.
Yeah.
Because we know that people with type 2 have a certain type of obesity. We call it central obesity. And you get unrealistic expectations to be skinny mini. So thank you. I'm sorry to interrupt.
Yeah, because most people gain weight over time, everybody. So if you can at least kind of maintain that, fight that increase and hopefully decrease is important. And then when it comes to exercise, when people hear that, they think, gosh, I got to put on like a leotard and go join a fancy gym, like whatever. Really, the recommendations are 30 minutes of some kind of sustained activity, 5 days a week. And that could just be walking, you know, around your neighborhood, whatever. You don't need to join a fancy gym, but that kind of amount of activity can really help with that insulin sensitivity that you were, you know, talking about. So when it comes to diet and exercise, to be like as simple as possible, whatever diet people can adhere to try to lose a little bit of weight, and some activity at least 5 days a week is really kind of the core of what that means.
Yeah, I don't go to the gym anymore, but I haven't thrown out my leotards at home alone. You know, I think the key is you have to do what works for you.
Yeah.
There's a lot of diets out there. There's the fasting diet, the Mediterranean diet, the Atkins diet. You know what? You got to find what works for you that allows you to, in a safe way, maintain or reduce your caloric intake while you're trying to build your exercise. By the way, we're not going to talk too much about lifestyle, you know, but we do have some excellent videos in the TCOYD video vault, given by some excellent exercise folks, and of course Adriana Valencia.
And a whole topic on, you know, weight loss, because, you know, people, not to get too off topic, but they'll say, can I get cured of diabetes? And it's kind of nebulous. The basic answer is it's kind of no. But if you want to come off of medications, and if that's your goal, then really it's about weight loss. And it can take kind of profound weight loss. But again, if you can target at least that 5%. But for example, when people are on a bunch of medications and they undergo bariatric surgery and they lose like 100 pounds, they can come off all their diabetes medications. But why we say it's not really cured is because the weight can come back and then the diabetes comes back with it.
Yeah, be careful of anything you read on the internet that says, you know, we can cure your diabetes and get you off all your drugs.
Yeah.
Now, if you use the word reverse diabetes, that's sort of like, you know, that's probably close to okay.
Yeah.
But as my good friend Dr. Pettis said, yeah, you could lose a lot of weight, get off all your meds. You're not cured, but you're under extremely good control.
Right.
And cure means it goes away and it doesn't come back.
So, all right, so you start your diet and exercise, blood sugars are still high. The first drug that basically every endocrinologist tends to reach for to treat type 2 diabetes is something called Metformin. And if you have type 2 diabetes, you're probably either on it or have at least tried it. And why is that like our first line kind of best choice? Well, it's been around forever. It's very cheap. It's very effective. So that's a lot of things going for it. It tends to be well tolerated, but it can cause some diarrhea or GI issues in people. So that's probably the number one reason that people stop taking it. We also don't use it in people with really kind of severe kidney disease. But if you're kind of a run-of-the-mill type 2, this is the drug that we use first. You can get it, you know, a month's supply for probably a couple bucks. I mean, it's very, very cheap. So that's where we start. And then after, anything about Metformin you want to say?
No, I would say it's super safe.
Yeah.
And I was going to say one thing, you know, there may come a point in time where that's not going to be the recommended first choice after you hear about some of these newer drugs.
Which I think is probably coming soon and probably should.
Yeah.
The other thing about Metformin, they're kind of horse pills. I mean, they're big, you know, pills that you got to take, so that's kind of an issue. But
well, horses have no problem.
Yeah,
that have diabetes. You know,
don't give your Metformin to your horse, because then you won't get any better.
You know, we should mention sulfonylureas.
Well, so yeah. So
go for it.
after Metformin, then the kind of like the doors open into all the different things that your provider may choose for you. And we have like 12 different classes of medications. We're going to focus on a couple of them. But as Steve was mentioning, there's this class of medication called sulfonylureas, which have been, like, we can't kind of get rid of them. They've been around for a long time. They're called glipizide, glyburide, you know, Amaryl, these types of things that a lot of people you've probably heard of. Again, they work. They can lower your A1C by 1% or so. They're very, very cheap. However, they cause hypoglycemia, they cause weight gain. They tend to kind of stop working after a period. And if you have type 2 diabetes, or even if you don't have diabetes, who wants to gain weight? Nobody wants to gain weight.
Yeah.
And who wants to feel low blood sugars? Nobody. So we're trying to get away from these medications because they're just not, we have so much better options.
Yeah, when Jeremy was born, I was 25 years old, treating people with type 2 diabetes. We had literally two choices of pills, Metformin and sulfonylureas. And then we also had some of the older insulin when needed. And I think most diabetes specialists are trying to get away from the sulfonylureas if we can.
Yeah. The only reason to use them really is if cost is an issue. Because again, you could pay out of pocket and get these for like $5 a month, maybe even less. But if you have insurance or anything, like, you know, any ways of getting kind of newer medications, you absolutely should not be on these medications because there's better choices.
Yep.
So if you're looking at your pill bottle right now and it says glipizide or something, you might want to talk to your physician about it. So
could I hold this up for a second?
You can hold it wherever you want.
In line with what Jeremy is saying, the new treatment algorithm that is educated to all the prescribers that see people with diabetes, they tell us to focus on 4 areas, probably in this order, but at the top you see heart disease. So like if you're a patient and you're sitting down for the first time, one of the most important things we're going to ask you is, do you have any history of heart problems? Heart attacks, strokes, congestive heart failure. We'll talk about that more. Next is, are you concerned with low blood sugar in this patient? 3, are you concerned about weight gain? And that's always yes. And cost. So these are the 4 areas that we focus on. And then
yeah, I mean, you're probably looking at this and say, like, gosh, like, I want all those things, you know, like, I want to lower my heart disease, I don't want hypoglycemia, weight gain, and cost. So, you know, the medications that basically after metformin that we're moving to now is, because this is alphabet soup, I love that you printed these out, because, you know, you folks have been saying that when we do these live things, we can't put stuff on the screen, so we hold these signs. So, there's these drugs called GLP-1 receptor agonists. Don't worry about what it stands for, glucagon-like peptide 1, and then SGLT2 inhibitors. So we'll talk about these one at a time. Do you have a preference of which one you want to go with first?
Well, I think let's talk about the GLP-1s first. Okay. Why don't you hold that up and so they know the names for a little bit.
All right, you can put your sign away.
Yeah. Okay, we'll get to those.
So GLP-1s, we got basically 3 main options of drugs in this class: Trulicity, Bydureon, and Ozempic. Now, these are all once-a-week injections. So, you know, to say that another way, you take it every Monday or something, you do an injection, it's actually very easy to use.
Yeah, the other thing I forgot to put on this list is an oral GLP-1 called Rybelsus, Rybelsus. And that's an oral form of an injectable. Mm-hmm. You take it every day, and there's some specific instructions. So it comes down to personal choice.
But so the way that these work, real quick, is that basically they do a couple things. They help your own pancreas secrete a little bit more insulin. They actually work directly on the brain to make you less hungry. And they also kind of slow down the way that you absorb food, so you don't kind of, you know, everything doesn't hit your system all at once. So when you put that all together, what happens with these drugs? Well, they lower your A1C, your blood sugars, pretty profoundly.
Yeah, more than most other drugs.
So, you know, maybe like 1.5%. So if you're at 8, you could come down less than 7, or 8.5, you could even probably get to 7. So, excuse me, blood sugars are better. And because you're eating less, people lose weight. And sometimes a significant amount of weight on these drugs. So a lot of these now have higher dose options. Ozempic, for example, has a very, a higher dose version of the same drug that's called Wegovy. And Wegovy is indicated for obesity, specifically for weight loss. And people on that drug lose as much weight as they do, or similar amounts to kind of bariatric surgery. So you got kind of the diabetes like level or dose, if you will, and then the dose for obesity, and you could be on either one.
Yeah, some of you may be on another one of these, that's not room on the sheet, Victoza, that's a once daily, and they actually have a higher dose. And then Trulicity, some of you are on Trulicity, which the original doses were 75 or 0.75 and 1.5. Those are the 2 levels. Then they just got approved 3 and 4.5. So all of these companies are now studying these drugs in higher doses to get bigger drops in your A1C and bigger drops in weight. Yeah. And I should mention an excellent endocrinologist named Jenny Luna, who spoke about these, and I did the lecture with her, but I pretty much was the moderator. It's on our website in the type 2 section. And the other nice thing about these drugs is we know their side effects, and it's a lot less than bariatric surgery. Yeah. So you want to go through those?
Well, so I would say first, why do we like these drugs? They work really well. Blood sugars come down. People lose weight. They do not cause hypoglycemia. Very, very important. And also, these drugs have now been proven to reduce the risk of heart disease and potentially of kidney disease.
Everything but cost. They get 3 out of the big 4.
Yeah. And, you know, if you have insurance, these are covered. So your out-of-pocket costs generally will be fairly low. You know, but if you had to pay out of pocket, would it be, you know, extremely high? These are still kind of brand name drugs.
Yeah, they're covered by Medicare. And I would encourage anybody to investigate patient assistance programs. And we have information on our website as well.
And if you heard injection and got, you know, squeamish about it, honestly, these things like these injectors, sometimes there's pens that you use that you don't even see the needle. Again, it's once a week. they really typically do tend to be painless or very mildly painful. So I hope that's not a barrier for people, because these are such great medications to really consider because of all their benefits. In terms of side effects you mentioned, because you can feel really full and not want to eat as much, it can feel like you're nauseous. And sometimes people even do vomit. That tends to be in the first month or so after starting it, and about 30% of folks will experience that, meaning 70% will just have no problem. But if you can kind of stick with it and get over that titration phase the first month, people do tend to do really well.
Yeah, it's all about slow titration.
Yeah.
And the companies have these set titration numbers. Like, let's just take Trulicity, 0.75, 1.5. And you should never go to the next level if you're still having a little bit of nausea.
Right.
And I would say, in my experience, most people, the vast majority, do really well. 20% might experience some mild nausea. And every once in a while, you get someone that has severe nausea.
Yeah.
So, and even some of these other pens, like Ozempic and Victoza, you can even titrate it slower than the prescribing guidelines. So go as slow as you want. The first GLP-1 was Byetta, which was the once-a-day form of Bydureon, which is once a week now. So this drug was approved in 2006. This is important. We know that the real safety issues of this drug. It's withstood the test of time.
Yeah.
No
that was
surprise.
a long time ago. So, some of these are new formulations, but this concept we've been working with for almost 20 years now. So this isn't something that you're going to be a guinea pig by any means.
Yeah.
These are very safe, very efficacious, honestly, kind of like paradigm shifting medications that we have these now. So you want to talk about?
Yeah, give me one more second.
Okay.
This heart disease issue, this may be too much information for you, but if you're a medical student, no. In general, the GLP-1 receptor agonists, these drugs that we're talking about, when they looked at how they reduce heart disease, these were serious studies, 10,000 people in these studies versus a fake pill. And they reduce heart attacks, strokes, and death due to cardiovascular disease, big time. And the FDA has given them their official listing, so they can actually advertise that on those goofy commercials you see all the time. So the heart disease is a big deal because it's the #1 cause of passing for both type 1s and type 2s.
Yeah, I mean, heart disease is the #1 cause of death for everybody in the United States. But if you have diabetes, that risk goes up 4 to 10-fold. So people with diabetes are just, we already have a high risk of heart disease in general, and people with diabetes are even at a much higher risk.
Yeah. Now these two drugs, I wrote it in Swahili. Let's give them the English version.
Okay, Soliqua and Zoltify. So what these are, and again, we don't come up with these names, but we do apologize that these can be a mouthful. So what are these? Well, these are both basically a combination of a basal insulin. So if you're on an insulin like Tresiba or Lantus, it's a once-a-day insulin. These now combine that insulin with a GLP-1. So every time you take an injection, you're getting your insulin and your GLP-1 together in one shot. So if you're somebody who is on basal insulin and a GLP-1 or considering both of those, these are options to kind of think about.
Yeah.
Because the way, the benefit there is that you're really combining into one injection, you're getting the benefits of both.
And what's interesting about these two products, they both contain a GLP-1 and basal insulin, as Jeremy said. And the way you titrate here is 2 units at a time. So it's much slower than we typically titrate the other GLP-1s when we use them alone. And the GI side effects are minimal.
Right.
So
there's a nice way that you can just slowly titrate your GLP-1. So that's a lot on GLP-1s. So bottom line, that they're great options, and that basically most people with type 2 diabetes should be on these drugs. And it might not be soon before these become first line, even before Metformin.
Yep.
Along with this next category, SGLT2 inhibitors. So real quick, sodium glucose transport 2 inhibitors. So what these do is they basically block the kidney's ability to reabsorb glucose. So you pee out sugar.
It hurts like hell when those sugar cubes come out.
It does not. You won't notice it at all. Your pee doesn't look different, smell different. You're not peeing more at all. But when you pee out the sugar, you're peeing out 80, 100 grams a day. That's about 300-400 calories. So people's blood sugars improve. They again lose weight. These are oral pills, generally once a day pills. So if injections are an issue, this is kind of a way to go for you. And the data keeps rolling out in terms of benefits to heart disease and chronic kidney disease. I mean, it honestly seems like every week there's some new indication that, to be honest, when we first heard about these drugs, like, oh, you're peeing out sugar, they're messing with the kidneys, are these going to hurt the kidneys? And exactly the opposite. These help people avoid going on dialysis and getting renal transplants. People that have heart attacks or strokes, they are much less likely to get another one. And the risk of death is lower when people go on these medications. So these have been, again, another huge breakthrough for people with type 2 diabetes. And if none of that matters to you, just a once-a-day pill that helps your diabetes and you lose weight.
Yep, lowers your blood pressure a little bit as well. Could I just expand a little bit on the heart disease? So it hits 3 of the 4 as well. And as I told you before, the GLP-1s is primarily heart attacks, strokes. These are, the SGLT2s really prevent congestive heart failure. And congestive heart failure is a particular situation where your heart's not strong enough to pump the blood around and your body retains fluid and the fluid goes in your lungs. If any of you have had CHF, you know what I'm talking about. And that's a very serious red flag, because once you've had one episode, you're much more likely to have another. Mm-hmm. And these drugs attack these issues. And when they did the big studies, you see the difference between the people who got the drug and the placebo pull away within weeks, the difference in CHF, hospitalization for congestive heart failure, death due to congestive heart failure. And then the other big thing is the kidneys. That they, like you said, they discovered that in these large heart studies, hey, how come these folks' kidneys are doing much better than the people getting the fake pill? And now Farxiga and soon Jardiance have the official indication for the prevention of kidney disease and the progression.
Right.
That's big.
And what's amazing about this now is that these are indicated to reduce the risk of congestive heart failure, chronic kidney disease in people with and without diabetes. So these have just been a breakthrough in terms of keeping people's hearts and kidneys healthy, regardless of if you have diabetes or not. So this has moved beyond a diabetes drug now to just a way of keeping these vital organs working.
Yeah, and the official indication is with and without type 2. So let me tell you about myself in a couple sentences. I'm 66. I got type 1 when I was 15. I have developed some chronic kidney disease. My kidneys are working about 50%. And I go to a kidney doctor, Bethany Carl. There's a video in our video vault about this. And she looked at this data, and the indication is with and without type 2. And it says it in the package insert. I don't have type 2. I qualify. It also says not recommended for people with type 1. And the companies have to say that because they didn't do large formal studies. So I'm on Farxiga, 10 milligrams a day. And I'm feeling pretty confident that that's going to slow my kidney decline. I can't say eliminate it completely. And I do the other things. I take an ACE inhibitor, a blood pressure pill, and I make sure my blood pressure is good and all that kind of stuff. So it's really opened up the door for heart and kidney in addition to diabetes. Now, the other thing it has is it created a much greater communication between the kidney doctors, the heart doctors, and the diabetes doctors. Like, we now talk to each other. They have much nicer cars than we do, but at least we talk to each other. And I love it when I see a patient for the first time. I see that they have some kidney disease and they're already on one of these drugs because their kidney doctor did it.
So I think, to walk somebody through their kind of lifespan of having type 2 diabetes, from diagnosis to, let's say, they've had it 20, 30 years.
Careful with that hand.
Oh, sorry. I was just trying to get rid of you. Again, starting with lifestyle, diet, exercise, adding metformin. And then our next two choices would be one of these drugs. And I'm not so picky about the order, but usually we probably do the SGLT2s first because they're pills. You can actually combine some of these with metformin into one pill. So get on metformin and SGLT2, then a GLP-1. So those first 3 drugs.
Say it slower.
Well, we've said it a million times now. So you get on metformin, and then both of these drugs would be kind of the next combination. And after that, then it would go to insulin. And insulin is still very efficacious. It's something that we try to avoid, but only because it can cause weight gain and things like that. but it's most people with diabetes do still go on to need insulin, so it's not something that should be feared.
Yeah, I mean, if you look at these treatment guidelines very closely, we're sitting down with a patient. They have multiple risk factors for heart disease, high blood pressure, cholesterol, weight, or they've had an issue. If they have kidney disease or congestive heart failure, then you should officially start a GLP-1 receptor agonist first, Jardiance, Farxiga. If they've had a heart attack or stroke, then we start with a GLP-1. But the important point you mentioned is, no matter which one you start with, if the A1C doesn't reach their goal, you add the other.
Yeah.
And you can use these two together, and that's like protection on steroids.
Mm-hmm.
They both protect the heart. And it turns out that the GLP-1s are also turning out to protect the kidneys, maybe not as potently as the SGLT2s. Sorry about all these acronyms, but yeah. Now, the other thing is, in this treatment algorithm, they say these other areas of concern: hypoglycemia, weight gain, and cost. And so what's awesome about these two classes of drugs is they both lead to weight loss, and they both do not cause hypoglycemia in and of themselves. Mm-hmm. The older sulfonylureas that we talked about and insulin, those are the only two classes that cause hypoglycemia. Now, we didn't mention DPP4 inhibitors.
Yeah.
Like, what's the
Januvia is the most common.
Thank you.
So it's a great medication, but it just didn't tend to be as efficacious, and you can't use them with the GLP-1s. You got to kind of pick one or the other. So given a choice, I always use the GLP-1, so I'm not using the meds like Januvia much anymore.
Yeah, I never liked the word Januvia. I thought it was anti-Semitic, being Jewish. Januvia. That's just my joke. Okay, I'm Jewish. I can say that, right?
Okay, yeah. All right, let's do these cases that you wrote down here.
Well, let me read it through, and then you can comment.
Well, I'll read it.
Okay.
Okay, case one, Larry. This is a real case. Is a 63-year-old male who was diagnosed with type 2 diabetes 25 years ago. In the last year, he had a heart attack and an episode of heart failure. He's on metformin and glipizide for his diabetes, and his A1C is 8.5%. He also has high blood pressure and elevated cholesterol levels. Kidney function is normal. So what do you think about this case?
Yeah, well, he needs a medication urgently. Now, having a heart attack, I'm thinking GLP-1. Having an episode of congestive heart failure, I'm thinking SGLT2. So at this point, I'm thinking that I'm going to start one and probably add the other. We don't start those two at the same time. And I'm kind of concerned about the congestive heart failure. That's a real acute thing. So I might start a Jardiance or Farxiga first, see where the A1C levels off. And then even if his A1C is in a pretty good range, I'm going to try to find a reason to add a GLP-1 to that, like Trulicity or Ozempic or Bydureon, and then try to take off the glipizide.
Yeah.
So I don't have to worry about hypoglycemia and then the weight, because you're already having drugs that reduce weight.
Right.
So
this guy's on glipizide, not doing well. Our goal would be eventually get rid of the glipizide and replace it with both of these new drugs, the SGLT2 and the GLP-1. And with that combination, his A1C would probably be less than 7. You'd be, better off in terms of his history of heart disease. And then we can't forget about high blood pressure and cholesterol levels.
Thank you.
When it comes to heart disease, the things that actually are kind of more important than blood sugars are the cholesterol and the blood pressure. So we always want to address those at every single visit with your endocrinologist, with your provider. Hey, what are my goals for my cholesterol? What are my goals for blood pressure? Essentially, everybody with type 2 diabetes should be on some kind of cholesterol-lowering medication. We use a lot of statins like Lipitor, Crestor. These have gotten a really bad rep, from side effects and things like that. However, so efficacious. Once a day pills, you can cut your cholesterol by 30 to 50% with just one of these pills. If you stopped eating every kind of fat in the world, you would come nowhere close to like that kind of reduction.
Yeah, the statins have gotten a fake news situation.
Right.
They have saved more people from having heart attacks and strokes than any single medication.
But I think this is a good example of when I see somebody like Larry, I get excited because there's so many opportunities to make this guy healthier and probably happier, losing weight. And so, but you got to take Larry with you on that ride. You know, he's probably thinking, gosh, I'm going to see this doctor and he wants to give me 6 medications or whatever, switch things around.
Yeah.
And I'm really thinking, gosh, Larry, if we get you on these different meds, you're going to live a longer, healthier life. You're going to lose some weight. So it's about changing your mindset that these medications really, it's an opportunity.
Yeah. Now, what about aspirin?
What do you think?
I think absolutely.
So what's your kind of guidelines for using aspirin?
Well, for the average person with diabetes, if you get over 50, 1 baby aspirin a day. And the aspirin is like, first it's popular, then it's not popular, but 81 milligrams is super safe, enteric coated. I get mine at Costco along with my 2 big tubs of Skippy peanut butter. and I think the data for me is clear. Making your blood a tiny bit thinner, it's a blood thinner, but nothing compared to the heavy duty ones. It can help reduce heart attacks and strokes.
So we really, we talk about the ABCs and actually ABCDs now of heart disease, and it's good to go over that. A stands for getting your A1C less than 7 and a baby aspirin, 81 milligrams. B is your blood pressure. Generally, we want that a higher number, less than 140 or so. If you're above that, you definitely need to be more aggressive. C is for cholesterol. The goals keep changing. We're moving away from just like what your cholesterol number is to if you're at higher risk, you should be on kind of a statin medication. So addressing your cholesterol. And D is for these new drugs, these kind of heart-specific drugs that you might want to consider. So those things should really be addressed at any endocrinology appointment, even any primary care appointment you go to.
And we don't want to get too detailed, but when you get your cholesterol panel, your lipid panel, the total cholesterol is not that important. What is important is your LDL, L for lousy.
Mm-hmm.
We want that for sure less than 100. And if you already have heart disease, less than 70. Then there's HDL, which is like H for high. The higher, the better. That's the protective. Exercise can raise that. Drinking a little bit can help that. But mostly it's determined by your family history. And then there's triglycerides. How do you explain triglycerides to someone?
Usually I don't, to be honest. I mean, because unless they're like extremely high, it's
Come
something that we don't have to like really talk about. But, triglycerides are not as important as, the LDL and HDL and things that you've mentioned. So I don't know.
It's a form of fat in your blood. Yeah. It typically goes up in people with type 2. It parallels glucose control. It's important to look at because if it gets really high,
and then we do have medications that can address specifically high triglycerides. So what about this other case? Case 2, Rita, 57-year-old female with type 2 for 12 years. Her diabetes and her blood pressure has been consistently elevated despite being on metformin and basal insulin, Toujeo. A1C is 9.1% and blood pressure 135/90. No history of heart disease, but kidney function is down by about 50%. This is technically stage 3 kidney disease. So what do you think?
I think when I see that kidney function 50%, I'm thinking SGLT2 right away.
Yeah. I mean, and first of all, it's worth saying that this last person was on metformin plus a sulfonylurea like glipizide. This person's on metformin plus a basal insulin. And in both of those cases, that's just not what we would recommend as a second choice above metformin, regardless of all this other stuff.
Yeah.
So there's an opportunity right away to say, you probably don't need insulin. We can, maybe you do, but let's try some of these other medications that are going to benefit you and then see where you land with your A1C. And then if we have to use insulin, then maybe go that way.
Yeah. The other nice option that you could use after SGLT2 are these combination of basal insulin plus a GLP-1 receptor agonist. And they've been shown to really drop people whose A1C is above 9%. Yeah. But as you can see, there's many ways to skin a cat. But I do think that these 2 new categories that you should have memorized by now are 2 of the most significant classes of medications we have. And we couldn't have said this a couple of years ago.
Yeah. And so that's really the point. You have to advocate for yourself. Hey, I heard about these medications. Should I be on them? We don't take that, personally. That doesn't offend us. If somebody comes in asking questions about what, something they heard or read, that actually helps us, I think, engage in conversation, that this patient is, somebody who's motivated about their health. So don't assume that whatever, drug is just prescribed is necessarily, there's a lot of options, which is actually where our job gets kind of fun. And if all these words are still gobbledygook to you, that's okay. You just know that these classes are something that is out there that you can definitely talk to your provider about. Other things about that case, we're going to do an SGLT2, we're going to do a GLP-1, same kinds of things.
I think the main issue that should stand out is that this person has kidney disease.
Yeah.
So SGLT2 is going to help you with glucose, weight, protect the kidney. and not cause hypoglycemia. And then that's the first step. And then, within 2 to 3 months, you got to see where you level off, like you mentioned, and see what's next. And please don't worry about the number of medications you're on, because you want to control your blood pressure, cholesterol, and your diabetes, but also protect your heart and kidneys at the same time. So we have incredible options. And I do think that now that these drugs have been out there and they're following patients over a longer period of time, you're going to see some more data showing how it reduces more what we call morbidity and mortality, sickness and death.
Well, listen, type 2 diabetes is no fun, diabetes in general. And, it's not easy to take medications every day or even every week. But a good thing about these drugs is if you start taking them, generally you will see the benefits. Literally, in the mirror, losing weight and with your blood sugars and your health. And that can help people stay on course. Nobody wants to just take a pill every day and then, you gain weight or your blood sugars go low. But if you start seeing the benefits, like in real time, it can help people buy into, like, this is something you're going to be dealing with for potentially the rest of your life.
Yeah, just remember this famous statement by Sir William Osler that I learned from Dr. Polanski. The way to live a long and healthy life is to develop a chronic condition and take care of it. And I am so convinced that when people get diagnosed with type 2, they say, oh, all these asymptomatic problems, these issues they didn't know they had, blood pressure, cholesterol, diabetes, they don't feel that bad. But once you get those under control, you feel a lot better. And I'm convinced that they're going to live a longer and healthy life than if you had never been diagnosed with type 2. You start eating better, you start exercising. And, you and I showed data on that, and so does Dr. Polanski. You could live longer than someone your age and sex and weight.
Yeah, because exactly. So let's do some of these questions pretty quick since we're kind of out of time. Is that okay?
Yeah.
So I take metformin. This is from this person. I take metformin, Tresiba daily, and Ozempic weekly. I experience lows and highs. Why? Is this the diet? It's hard to say. So basically metformin, Tresiba, Ozempic, still kind of oscillating. And it's, the food is definitely going to make your blood sugars go up. But if that's consistently happening, it might be time to add something else. Talk to your provider about potentially adding on insulin or, adjusting food, whatever. But it's hard to give specific advice without seeing the actual blood sugars and how high and how low.
Well, here's the thing. A lot of people will come to me, oh my God, my blood sugars are fluctuating. They go from, 80 to 140. So there's a certain amount of up and down. Now, the other thing is you're on
So that's what like a non-diabetic person will have those kinds of fluctuations.
Yeah. So
and our goal is to keep, that after meals, you stay less than 200. So if you're going up to 180, 190 after meals, that might be okay, depending on what your A1C is. So don't get too hung up about the ups and downs.
And if you're getting really low, like shaky, weak, sweaty, you're on too much basal insulin.
Yeah.
I would suggest to you to get a continuous glucose monitor.
Yes.
Both Abbott and Dexcom have these free trial programs. And then you can really see what's going on 24/7. And then you show that to your caregiver and they can fine tune your control.
And, along those lines, it might be where they just prescribe you like a little of mealtime insulin, take 2 units with a meal, because if you're on mealtime insulin, it tends to be much easier to get a continuous glucose monitor. So.
Oh, I see. Yeah, to get it approved. Yeah.
Yeah.
That's a good thought. We'll give you a pseudo injection so you can get approval, but it can give you a lot of information.
It's huge. Can you have alcohol once in a while on metformin or any other meds? Tis the season after all. So first of all, we've done a lot on alcohol because this is like such an important topic, because people drink, they want to have information about it. On our video vault, we did a great video where Steve and I actually I drank beer, he drank hard alcohol in real time and saw what happened to our blood sugars. So in general, the ADA, American Diabetes Association, recommends 2 drinks a day for men, 1 for women. For people with diabetes is okay. What about metformin and alcohol? What's the bugaboo there?
No problem.
I think it's overrated.
No problem.
So basically, try it. If you have some big adverse reaction with having any alcohol while on metformin, don't do it. But chances are you won't.
I've never heard of it, so forget that.
It's just like everything else, moderation. Just like just the way that other people should consume alcohol is the way that people with diabetes should.
I know it's in the small font on the package insert for the drug, but you have to look at what's clinically relevant versus something that happened once to 1 or 2 people that make the drug companies have to publish that. So metformin and alcohol is safe, but as Jeremy said, everything in moderation. So take it easy on the metformin.
Can one go off blood pressure and statin meds until losing weight affects on liver? Will doctor take me off Dexcom? So there's a lot there. I don't know. But in general, I mean, I'm guessing the question is, if you lose a bunch of weight, can you come off these medications? And it depends. Certainly some of your blood pressure would probably improve. Some of your blood sugars would definitely improve depending on how much weight you lose. Will doctor take me off Dexcom? So I'm not sure. So again, for type 2s, you generally have to be on insulin to be on a continuous glucose monitor. If it's already gotten approved, I think it'd be kind of harder for them to take it away.
Yeah.
So I wouldn't worry so much about
Yeah.
that.
Fight for your CGM.
I've been controlling my diabetes through diet, but numbers are climbing. Should I start Farxiga? Again, case by case. Our goals are keep your A1C less than 7. If you're able to maintain that without medication, more power to you. If they are still climbing, again, technically our first drug of choice would be Metformin, but going to Farxiga straight away, not a bad idea either.
I would just say that if you had any issues at all with your heart or your kidneys, even at the beginning where you have a little bit of protein in your urine, that's a good reason to start a drug like Farxiga or Jardiance, and then also you could use that to get approval. Everything's about getting it approved.
My type 2 husband is on Soliqua. He takes 60 units every morning. We notice his blood sugars tend to rise early each morning, well before his injection. Is there another option that will make it last longer? He also takes 20 units of Novolog at mealtime. So it might be, that sounds like the Soliqua dose or the basal insulin is probably not high enough. So there's other basal insulins they could do. Again, making sure their SGLTs, there's a bunch of different options. You'd have to know their blood sugars. This is somebody that also a continuous glucose monitor would be a great idea.
Yeah, it's much, there's no way we can give you specific ideas without seeing the 24-hour, and we're not your doctor anyway, so please, everyone listening, watching,
well, I think
don't start something because we said to.
When I do these talks, honestly, I'm jealous as somebody living with type 1 diabetes, and all we got is measly old insulin. I mean, God bless it, keeps us alive. But like having all these options that have just like profound effects on health is pretty awesome. And people need to be, aware of it. We're still seeing all these patients come to us on sulfonylureas and basal insulin, and these are getting easier to prescribe, to get covered. We mentioned the GLP-1s have been available since 2005. The SGLT2s maybe 2013, something like that.
No one says SGLT2 is faster than you.
Well, anyways, these have been around for a long time.
Yeah, they've been around a long time. Yeah.
We got our signs, so I think they know it. So basically, it's a new day for living with diabetes, and these are opportunities to take charge of your health, get on these medications, and really ultimately the goal is to feel better, live longer, live a healthier life, which people can do.
Yeah, well said, my friend, and have a good conversation with your healthcare provider about it.
Yeah.
So I think that's it.
Well, thanks. This was fun. Thanks for printing these out. I hope you guys appreciated that. Steve, see, these aren't printed. Actually, Steve wrote these with Sharpie. They look really good. All right, guys. We'll see you later. Thanks for stopping in, and have a good one.